and welcome to Brewing Brilliance, a podcast where we talk to academics from across the university who are involved with the Healthy Ageing and Chronic Conditions Research Institute. We will be speaking to researchers who are leading innovative interdisciplinary approaches to promote lifelong health, delivering improved interventions to manage chronic conditions more efficiently. These sessions are essentially opportunities for us within the Healthy Ageing and Chronic Conditions Research Institute to meet colleagues from across and beyond our faculty to foster knowledge sharing, collaboration and networking. My name is Adrienne Cleverly, and today we are joined by Dr. Sarah Pryor, who is a senior lecturer within the Diabetes Research Group in Swansea University Medical School. Sarah's research has focused on investigating the links between type 2 diabetes, obesity and their associated comorbidities. This includes the identification of molecular biomarkers for the association with specific cardiovascular disease, as well as having a keen interest in bariatric surgery and weight loss. Today, we're going to be discussing her current research in the bariatric phenotype and how bariatric biomarkers relate to health and surgical outcomes. Hello, and thank you for joining us.
Hi, thanks for the invite.
So that's quite an impressive introduction there. So for simplicity and ease us in gently, can you start by telling us a bit about what bariatric surgery is?
Yeah, no problem. So bariatric surgery is the only evidence-based approach to sustainable weight loss. And when we say sustainable weight loss, we mean substantial sustainable weight loss. There's places for exercise and diet. However, if you want that substantial weight loss, a weight loss surgery is the only way forward. And it also as well has the added benefit of improving comorbidities such as diabetes, cardiovascular disease, and better survival rates, because these people, they're not going to outlive us all sort of thing. So therefore, after the surgery, their survival rates are increased. So therefore, the health costs of that are recouped back within about 3 years post-surgery. So bariatric surgery loosely is classified into two categories. You've got your restrictive, where your stomach is reduced in size and volume, and you've got your malabsorptive, where the digestive processes are sort of rearranged in order to create a different physiological condition of malabsorption in the body. The surgery that's primarily used in our area, and the one that we concentrate on with our study, is laparoscopic sleeve gastrectomy. And basically it's an innovative procedure that encompasses a bit of both processes. It's non-reversible. It reduces the stomach size by partial gastrectomy. So basically they go in with their little surgical tools and they cut 70% of the stomach away, and it creates this little tube of stomach that's left. It preserves the lesser curvature, so your stomach naturally curves to the side. It preserves that smaller curve and right the way down to the bottom of the stomach, the pylorus. So it's removing all this excess stomach size. So you've got the restrictive element because you're producing that smaller stomach, but also the malabsorptive element, and that comes from removing the majority of the incretin hormone cells that help with hunger and satiety feeling within the body. LSG, or laparoscopic sleeve gastrectomy, has been shown to be the most effective weight tool compared to other forms of bariatric surgery. So you've got other forms such as other restrictive forms of sort of gastric banding. Most people would have heard of that, where there's a little band, I should think of the word, a little band placed at the top of the stomach to produce a pouch. But there's a lot of problems that are linked with that itself. And there are other sort of more malabsorptive sort of forms, such as Roux-en-Y gastric bypass, which is very complex and a very long operation. Laparoscopic sleeve gastrectomies have a percentage excess weight loss, so that's how we measure the success of the surgery. And that's roughly around 60% of that excess weight is lost within just the first year after surgery.
Gosh.
So there's absolutely phenomenal results that come from it. And the advantages then include reduced hospital stay because it's done laparoscopically. It doesn't have to be an open surgery. The comorbidity resolution. So some people who have type 2 diabetes will have a resolution of that practically the next day after surgery. It's not necessarily weight related. It's all due to metabolic composition in the body, but it's favoured mostly due to its low mortality, shorter operative time, because you don't have to have a huge abdominal surgery, and lower operative costs as well.
And then, like you said, long-term costs as well in terms of what it saves.
So you can pull that back then compared to some of the more expensive open more complex surgeries that are involved.
So prior to surgery then, do people have to follow a specific diet or anything to sort of make sure they're ready or prepared or committed even?
So obviously these patients have come through the weight tier system, have undergone sort of lots of different weight management clinics and stuff like that, but they've ended up tier 4, which is the bariatric surgery clinic. However, during laparoscopic surgery, the tools are entered through little portals in the stomach, and the liver needs to be lifted up in order to get to the stomach, which lays underneath. Most people who need bariatric surgery, they're obviously morbidly obese, so you're talking a BMI of greater than 35, have large fatty livers, and that can cause issues for the keyhole surgery. The equipment's holding a lot of weight. They can't necessarily see properly because it's a large liver. So therefore makes it difficult for the surgeon to not only see but gain access to the stomach and do the operation correctly. So sadly, this can sometimes, if not dealt with, can increase the duration of the surgery. It can increase surgical risks such as bleeding, and in extreme cases can often mean that they have to go into open abdominal surgery if the surgery isn't cancelled totally anyway. So as part of routine care, and to minimise this, they undergo a thing called the liver shrinkage diet. Now, this is a really extreme low-calorie diet. We're talking 800 calories a day, 100 grams of containing less than 100 grams of carbohydrate, very low fat, with high protein. And it can usually last between 2 to 4 weeks, depending on the BMI of the patient and how big they are. But what's happening during that diet is that the body is forcing the liver to use up all the stored glycogen and water. So therefore, the liver becomes a lot smaller, hence the liver shrinkage diet, but also as well softer, more flexible, more pliable, so that the surgeon can actually lift the liver and it doesn't crack or bleed then during the surgery.
It makes the surgery easier, the process.
Yes, a lot easier for the surgeons. The process itself is found to be very successful. A lot of obviously, they've been told they need to do this diet in order to get their surgery. So a lot of our patients stick to this diet rigidly. But again, it's only for a 2-week period, so it's not
a long term.
It's not a life-changing
easier
thing
to commit to, isn't it, with a 2-week period? Yes. Yeah. So you find that's quite successful then? People do stick to it because it is?
They do, yeah. The surgeon can tell when they go in initially with the portals if they have or haven't. If the liver has decreased in size, obviously the surgery will progress forward. If it hasn't, if they've made some attempt and the liver has shrunk a little bit, not to necessarily the desired size that they want, but they're still possible to go through, they might continue with the surgery. However, if the surgeon goes in and they can see that they've made no effort, they've just basically lied on their form saying, yes, I've done the diet, they will cancel it because the surgery is just too risky for that cracking and bleeding of the liver.
Yeah. Oh, gosh, that's quite a heavy procedure. But then if you want to go through the procedure, I guess it's a tick box exercise.
Yeah, exactly.
Exactly.
It's a needed necessity.
Yeah, for your own
benefit.
For
your own health.
Yeah. So on that basis then, can you just tell us a little bit about the aims of this study and what you're hoping to achieve?
Yeah, so the bariatric phenotype study our aim is to collect these sort of pre and post liver diet stool samples to establish if low-calorie diets, especially this one in particular, can impact the gut bacteria of individuals that are undergoing bariatric surgery. We also then want to look at their post-operative stool and blood samples as well to see if this is carried on. So these changes are kind of carried on after they've had this extreme surgery, because obviously the body's changed. Yeah. They've had a lot of weight loss. Is this affecting the gut microbiome? What we also want to do, we've had a lot of little arms to this study, but secondary, to enable further understanding the relationship between obesity and gut bacteria, we're going to collect the resected stomach. So the stomach that's actually cut away is roughly about 60 to 70% of the stomach during a sleeve gastrectomy. It's usually classed as clinical waste and incinerated. We've got the ethics to collect the tissue. And what we'll do then is take samples from the top of the stomach, known as the fundus, the midsection, that's known as the body, and the bottom section, known as the pyloric area, to see if there's any differences and establish if gut bacteria populations related to not only health markers of the patient, but also as well how successful the outcome of their surgery is. So do they get better weight loss if there's a certain bacterial sort of ratio or something like that?
You did mention gut microbiota. Can you just, why is this so important to what you're looking at right now?
Yeah. So there are trillions of bacteria, collectively termed microbiota, that reside in our gastrointestinal system. They play a vital role in the pathobiology of obesity, and this has been documented for many years, sort of thing. The microbiota of the human gut is dominated by two phylums, the Firmicutes and the Bacteroides. Lovely names. And,
Easy to say.
Yeah. But in obese humans, the predominant gut bacteria are the Firmicutes. But what we've seen is that as people lose weight, this ratio changes and the Bacteroides become the more dominant form. And we want to assess whether this change can influence anything. But also as well, there's a link between gut microbiome and obesity in a twofold way. And firstly, it can increase the bioavailability of energy from non-digestible fibres. So usually your body would chuck away certain, go through your system, chuck away certain fibres, stuff like that, come out, be excreted. However, if you have a certain ratio in a certain format, that microbiota can then break down those undigestible fibres to form a absorbable nutrient that can be used for energy. The second way then is that they also regulate intestinal gene expression. So critically, it can affect certain proteins that can cause breakdown of certain protein substances, and as the release of free fatty acids, which the body will then use as another energy source. So therefore, your microbiome is literally adding to your energy.
Yeah, I was going to say, you've mentioned energy a couple of times there, so it's quite positive.
Yeah, it's giving another source for your body to use energy, create more fat stores, and add to this obesity potential within the body.
That can see why it's such an area of interest.
Yeah, so we need further research to investigate the true role of this gut microbiota in obesity itself. It's been documented in the past that there are these ratios and everything, but whether or not the gut rearrangement and the gut anatomy after bariatric surgery can play a role in this as well.
So you've a massive impact then in terms of moving forward for future research.
Yes, hopefully.
I'm going to change direction a little bit.
Yeah, no, go for it.
But what are the patient selection process for something like this?
Yeah, so our participants will all be recruited, and some already have been recruited, which is wonderful, from the Welsh Institute of Metabolic and Obesity Surgery.
Right, okay.
And these clinics are in Singleton and Morrison hospitals here in Swansea Bay Health Board. So WIMOS, that's what it's known as, provides all the bariatric surgical services for Wales and receives approximately 100 referrals per month. That's quite a lot of referrals. However, sadly, they only have the ability to do between 150 to 200 surgeries per year. And that's all down to funding, sadly. So we are lucky enough to have a really good relationship with WIMOS, have for many years. So we approach potential participants at their preoperative state, get informed consent, the usual things. We then can get some demographic data, such as, family history, medications, if they got diabetes, that sort of thing. Smoking status is a big one as well. Alongside sort of obviously the clinical measures that we need, such as BMI and weight, obviously, and blood pressure, that's a really important one. And then some biochemical measures such as glucose, so we know the state of the body when it comes to that sort of diabetes link as well, and also the lipid profiles, because they're going to be a lot of change when it comes to the fat mass that they're happening. So we do have a strict inclusion and exclusion criteria. Obviously, you got your patients that they have to be undergoing the surgery that we need them for. Both sexes, more than welcome to take part. Has to be between 18 and 65 years old. And obviously, we're going for that higher BMI category of 35 and above, because we want to look at this unique morbidly obese group of patients. We don't care if there's pre-existing diabetes, impaired diabetes, such as pre-diabetes, or if they got normal glycemia, that's fine to us. However, we do have a strict exclusion criteria. Obviously, If they're not undergoing laparoscopic sleeve gastrectomy, we don't want them. If they've been prescribed antibiotics 4 weeks before. Now, that's really important because antibiotics are obviously stripping the gut bacteria out. So we need to make sure that the bacteria that is there is representative of the obese state that they've been. They're normal. Yes, that's it. The other thing then is if they've undergone any gallbladder removal, because again, the sort of bile acids can have an effect on gut microbiome as well. So that needs to be taken into consideration. And then the other thing is any previous bariatric procedures, because we want to make sure that the results we're seeing are based on that surgery and not a throwback from another surgery that we didn't have any control over.
So the benefits, for something like this are huge, because it's benefits to the patient, benefits to research, but benefits to the NHS overall as well.
Oh, and massive. This
came, previous chat with you, but this came from literally an idea written on a napkin.
Yes. So for many, like I said, we've had a good relationship with the bariatric surgeons at Wimos. And for many years, Professor Barry, who's the head surgeon there, has said to us, "We've got all these stomachs. They're just being chucked away. Can we do something with them?" And we were just like, okay, but it's difficult, it's funding, this, that, the other. So we wrote a little grant, myself and Dr. Rachel Churm, and we put together an idea of creating this tissue biobank, where we collect the stomachs along with any bloods or associated things. So you're not necessarily just having a snapshot of these patients at that one particular time, but you can follow them from pre-op all the way through to post-op, and hence why we came up with the BP phenotype, the bariatric phenotype, which then encompasses that pre-liver shrinkage diet, but then follows them through their process of having the operation. And then we also collect stool samples and blood samples post-surgery as well, so that we can follow the gut microbiome all the way through to see the changes. So we've got the liver diet changes at the beginning that we can analyse, but also as well that any changes that occur as a result of the surgery itself, because this hasn't been looked at. So we've got that future element there as well built into it.
So what does the future look like for or shall I not ask you that yet?
No, to be perfectly honest, we would put a shout out, because we did the talk this morning. We'd like to put the shout out that if there's anybody who'd like to work with us, we are collecting these samples. There is a multitude of things we could measure in them and look at beyond what we have instigated. There's the inflammatory status of these patients that we want to look at. There's also looking at the incretin hormones themselves, such as ghrelin. They all play a role in this hunger, satiety feelings that we have, and I think that having these tissues opens us to an avenue of where we can investigate lots of things. But more importantly, none of these previous studies have been done in this unique morbid obesity cohort. So we have created this biobank for this cohort, so therefore we can gain some real understanding about the way things are working in this sort of field.
You've just answered my last question, because I was going to say, why is this so unique? And you've just literally you beat me to it. But on that note, that is so interesting, and so sort of it's amazing how it's just sort of come about, and how what opportunities can potentially stem from it. Yeah. And this is why I love talking to everyone that comes in, because I'm just get overexcited with everything. But on that note, I'm assuming you're happy for people to reach out to you.
100%, yes. My email is available.
There we go then. So thank you so much to Sarah for coming in today. If you would like to find out more, please reach out to her. You can visit her staff profile page, and her email is on there. If you have enjoyed and would like to find out more about this podcast and the Healthy Aging and Chronic Conditions Research Institute, or anything to do with the medicine, health and life sciences, please follow us. Please get in touch. Thank you. And thank you so much for coming in.
Thank you. It's been a pleasure.